What's going on, guys? Welcome to another episode of Healthspan Academy. I'm your host, Craig Shearhart, and joining me today is my special guest, Dr. Dan Karlin, who is an expert in mental health, cognitive issues, and treatment with psychedelics. He started his academic career with a Bachelor of Neuroscience with Neuroscience and Behavior from Columbia University. Went on to complete a master's in medical informatics and cognitive science and medicine, and then completed his medical degree from University of Colorado. He's currently an associate professor in psychiatry at Tufts University and the chief medical officer at MindMed. He's the author of 43 scientific articles, commentaries, patents, and chapters in psychiatry and substance user disorders. And he's an expert in the use and development of psychiatric drugs and the digital medicine devices. So today's mostly about the use of psychedelics in improving cognitive function and helping people resolve mental health issues. Dr. Karlin, thanks so much for being here, man.
Yeah, it's a total pleasure. It's really nice to meet you, and I'm excited to see where we can go with this conversation.
Likewise. So let's get into it. I want to kick this off with how you first got interested in cognition, mental health originally. I find the brain fascinating. It's just like it's a bit of an overload, but how did that come to your life originally?
Yeah, I've been interested in this for so long that I don't remember a time when I
really?
This is in as much as anyone could claim that they have something like a calling. I mean, it didn't happen like that. It just happened that I knew this was what I cared about. I mean, some of it's my family. My dad's a neuroscientist.
Okay, cool.
And I grew up in that environment. Kind of always knew that I wasn't going to be a wet bench science type person. That didn't appeal so much. But really, I always think I wanted to be a doctor. I don't really remember a time when I didn't. And I very quickly narrowed in on psychiatry and then addictions and clinical informatics as my other specialty, because there's this neat convergence between all of these different things, and they offer a bunch of opportunities to try to progress the field as a whole.
Absolutely. Very cool. And then I guess specifically to psychedelics, this is kind of like blown up. I guess maybe the tipping point was Michael Pollan's book. I think that came out and kind of the masses got a hold of this info. Then there's been the documentary on Netflix now. So it's blown up. How did your first interest in that, or what kind of piqued the interest for you in psychedelics, and what this potential might be for some of your clients or patients?
I was doing things that were psychiatric and drug development related. I built treatment environments. Mm-hmm. I worked at Pfizer as a psychiatric drug developer, and then in digital medicine at Pfizer, mm-hmm. and was aware of this undercurrent of swelling interest and seeming progression in a field that had been difficult to progress for a long time.
Right.
But I read Mike's book just like a lot of other people did as a psychiatrist, but I wasn't really tuned into just how far the psychedelic world had progressed, mm-hmm. and became incredibly interested in the potential for these drugs. But, mm-hmm. Partly because there's so much evidence that they've worked in the past and that they were put away for so long.
Yeah.
And partly just because I see the potential in the sort of way that these drugs affect people acutely. And look, we don't know, it'd be great if the acute effects, the psychedelic experience was the mechanism of healing. We don't know that to be true. Right. There are people who postulate it is, there are people who postulate it isn't. My guess is it's probably more complicated. It's probably both can be true, and it depends on the person and the disease and their background and
so many layers,
and all sorts of stuff. But my training in psychiatry wasn't just drugs, right? We tend to think of psychiatrists as the person who writes a prescription, and the psychotherapist is someone else. And that's not the way it has to be. And it's not the way it's always been. And so my training in psychiatry, like a lot of ours, had a great deal of psychological thinking, of depth psychology thinking, of thinking about not just the person as a collection of behaviors, but people as being complex beings with rich internal lives. And I think part of the excitement around psychedelics, and part of my excitement for sure, is the idea that it seems to be almost forcing a re-acknowledgement of the richness of the internal part of a person.
Right.
Even as, psychiatry over the last several dozen years has sort of drifted toward this like behavioral science, mm-hmm. which it's just not, right? Yeah. What we're really concerned with is human well-being. And that is the rich internal bits of the person. So there's this, I think part of the excitement is people want a psychiatry that acknowledges them in that way again.
Mm-hmm. Yeah, that's amazing. So going through the documentary, I don't know how much of that is like blown up and kind of by the directors and kind of blowing the results out of proportion or what have you. But so I want to get a picture of what your sort of top success stories have been with that style of treatment. best case scenario from point A to point B, what are some of the stories that stick out to you, type of transformations that people have seen?
Yeah. And so, I have to talk about other people's work in order to talk about the best case scenarios, because at MindMed, we are in development, right? We are taking primarily LSD, among other substances, but primarily LSD, which has more than 10,000 patient history in clinical studies, which is crazy to have a new drug that, it's been in that many studies and in that many people. And right now we've just started our phase 2. We're going to be dosing soon, our first participants. And so the success stories that we know about come from two places. They come from the body of research that the pioneers in the industry started doing again recently and historically. And then we know some things from folks who've obtained psychedelics as an attempt to treat themselves via mechanisms that aren't currently legal. Right. But I think that at their absolute best, what we hear is folks with longstanding either affective illness, so depression primarily, or anxiety disorders, getting better. And not having it anymore, which we can do with psychotherapy, by the way. I think is really important to say. I mean, not generally in one session.
That's the wild part.
Folks who do better on psychedelics might also not be one session, right? It might take maybe incremental improvements over a couple of sessions, and then maybe at some point there's transformational change and no need to continue doing additional sessions, which again mirrors psychotherapy. But the highest aspiration of psychiatry that we've sort of lost in the SRI era is cure. Right? Whatever that means to an individual, but fundamentally it means that they don't have to deal with this disorder anymore. Now, if someone had zero anxiety, that would be unusual, right? That's not the goal. There are good reasons to worry in the world today, but it's more
past
about
that point of being clinically considered.
Those being manageable and folks feeling like they're able to live. This part gets a little philosophically complicated. Like, what does it mean to be okay? What does it mean to be better? What does it mean to be good? And I've tried to put together working definitions over the years. But mainly it means being satisfied with your life and being able to make plans for the future that bring you more satisfaction, and get to those plans and evaluate whether they were right or wrong, and then repeat the cycle.
Fair enough. I love that. So most commonly we hear about depression, anxiety, OCD, those things being sort of rectified. And like, I guess best case scenario, it's just one session. Is there a sort of inclusion, like what type of symptoms that are most likely to get resolved through this type of thing, or most type of disorders have the best kind of results with this? We have a sense of that?
I think it's important when we talk about named symptoms and even named disorders to remember how arbitrary some of these distinctions are. That if going out into the world makes you so anxious that you've stopped doing it, so now your life is constricted around you, and you're isolated and feel down because you don't know which one's anxiety, which one's depression. They're just
constantly coupled together, almost seems like.
So we have to kind of hold two ideas in our head all the time. One is from a regulatory perspective, and from a payment and systems perspective, we need to have diagnoses and we need to have named symptoms and the ability to record them, and we kind of need to focus on the standard ways of measuring these disorders that you use to get a regulatory approval. And on the other hand, we have to remember that I'll give you 3 disorders as an example. The lines between depression, pain, and substance use disorders are not super clear, right? These sort of allegedly disparate entities tend to interact with each other quite a bit and have enormous relationships, which isn't to say there aren't patients who just have pain or just have depression or just have a substance use disorder. But many of the folks who end up with a diagnosis could have gotten a different one if they went somewhere else. And almost certainly are struggling with things on the borderline of their diagnosis and other diagnoses. So, we're hopeful. What we've seen from the evidence for LSD specifically is studies of depression, studies of substance use disorder, including alcohol use disorder, with full remission in some folks after one session, and then certainly anxiety symptoms. The some of the pioneering work that rebooted the field that you've certainly seen and heard about in Mike's book and other sort of things in the press was looking at end of life distress, which is end of life anxiety. There's a psychodynamic orientation that claims all anxiety is sort of end of life anxiety, but so if you're good at end of life anxiety, you're probably good at other anxiety too. But it's, in a world of psychiatric drug development, where the pressure on drug discovery and development was to find drugs that were increasingly precise, that increasingly had one identifiable, isolated mechanism of action, we haven't seen a whole lot of success. And that again speaks to these diseases as heterogeneous collections of symptoms. Psychedelics, while they do have a pretty specific mechanism by which they cause the psychedelic experience, they're doing lots of other stuff in the brain. And so, ordinarily when you have a drug that does a lot of stuff, you have to worry about toxicology. Here, these drugs are safe. The acute experience is generally safe. Certainly in a well-controlled environment, the acute experience is safe. And we know that they're safe over time, that people aren't, experiencing what you would ordinarily worry about from a toxicological standpoint. So it's almost like we've got to step in a different direction, acknowledge that the diseases aren't particularly biologically well defined, and then take drugs that seem to have this sort of universal change, that they help people move in the direction they want to move when they're given in the right circumstance with the right people supervising at the right doses. And so we're in an interesting space, which, and again, a lot like psychotherapy, which works across a range of disorders. It sure seems like we're dealing with, in the psychedelics class, a set of drugs that work against a whole bunch of different named diseases or whatever you want to call them.
Yeah, absolutely. And one of the most, I wrote a chapter on kind of mental wellness and the treatments and kind of stuff in my book I wrote. One of the most eye-opening things for me was the amount of overlap between, if something treats depression and anxiety, it also improves cognitive function. Those two seem to be coupled together and they seem to be treated the same. And what's interesting is now you got these two camps of psychedelics. You have these like biohackers that are looking in a microdosing, and then you have the other end of the spectrum, people that are considered mentally unwell that are kind of like going for the more transformative issues. So I want to talk a little bit about the microdosing piece and what a typical dose looks like, what the most common outcomes, I guess, that we're seeing, and is really the ultimate sort of thing that's going on physiologically, just neuroplasticity, and that's sort of the symptoms are sort of a result of that, or what. Talk a little bit about that.
Yeah, interestingly, as not to be contrary, and again, this is not in any way about what folks say about what they do, but from our perspective as drug developers, we've stepped away from the idea of micro, macro, or whatever else, just because so many other drugs that can be prescribed to you can be prescribed in a range that's a whole lot broader than what we're defining as micro and macro here. So we just think about drug dose. And generally, so when people are talking about microdose, or what we would call probably just subperceptible or low dose, they're talking about a dose that's somewhere near threshold where you'd experience a true psychedelic effect, and taking it more repeatedly. And of course, the more, if you were to take, say, LSD daily, the primary psychedelic effect actually gets blunted. It's called tachyphylaxis. It's the receptors downregulate so you don't actually trip anymore. So folks who are, say, microdosing daily or a few times a week are probably downregulating those receptors anyway, so they have less of a perceptible effect from taking it. What that does and how it does it,
still too new.
I'll tell you a lot of stuff, and I've got a lot of thoughts on these things, but I really try not to overstate the evidence. And when it comes to mechanisms in neuroscience has come an awful long way, and psychology has come an awful long way, but they haven't met yet. And so, when we postulate at their meeting points, we're doing just that. We're taking the evidence the best we have and guessing, but we need to acknowledge that we still don't really know how SRIs work, right? And those think about the prevalence of SRI use. So one of the interesting things about developing drugs to try to help people is that you can postulate about the mechanism all day, but at the end of the day, what matters is, did people get better?
Right.
And so you don't have to know how they got better to know if they got better. Right. So that's very much what we're focused on now. We've got a low dose, repeat dose LSD trial in ADHD that's currently enrolling in dosing. Nice. And so that for us is our attempt to somewhat answer, not the mechanism question, because that's a longer term project, right, but to answer the question, how much does this do? If someone's actually blinded to their treatment allocation, whether they're getting placebo or drug,
right,
and they're evaluated over time by impartial third-party blinded evaluators,
double blind,
does it do something other than what placebo does? And I think another really important thing when we talk about this is placebo is not a bad thing. It's only a bad thing in clinical trials.
Right. Yeah.
Right.
True.
In the real world, we assume
if you get better, you get better.
Yeah. And if I give someone a drug and they get better, we have no way of knowing what the drug did and what the drug didn't do. So true. And so some of that effect is placebo effect, even though they're not on placebo. Right. So I think it's really important for people to remember that especially as folks get wrapped up into the research world because they're interested in psychedelics and they know that psychedelics being prescribable depends on a bunch of research. So they're looking at psychiatry clinical trials for the first time, and everyone's talking about, this placebo effect's killing us. No, the placebo effect's helping people. Yeah. That's the problem with it.
Yeah,
true. So it really is it's two different views of the world,
right?
But it's the clinical trials are just a way to bring something forward to try to help people in the real world.
Yeah,
and so we have to wherever possible. Now, as a drug developer, we have to flip back and forth, but wherever possible, as a doctor, my view has to be oriented toward will people do better in the real world?
Right.
You've mentioned cognition, obviously. You mentioned the connection between cognition and depression before. As folks get older, and for folks with lower cognitive capacity, depression can be profoundly impairing to cognition. So there are older patients who will present with what looks like a kind of a sudden onset dementia, like a really fast Alzheimer's, and you always have to treat for depression,
right?
Because it particularly in older folks with lower, MCI or lower cognitive reserves, a depressive episode can look a lot like a dementia. We used to call it pseudo dementia. It's been renamed now, but we have to remember that those two are really deep.
Yeah, I love that. I want to dive into some of the sort of, I know the stuff's kind of still in development a little bit, but so when we look at the higher dose camp, people that do have a clinical issue, whatever that issue is, depression, anxiety, OCD, how do you arrive at a dosage? Is that like a set number? Is it like based on patient weight? Is it sort of until the signs change and they've had an effect? Or how do you arrive at a right dose when you start to look at administering that in a clinic setting?
That's a really good question. How do we think about dosing? And again, because a lot of the research on these substances was pretty old, and now we're trying to do a lot of more modern research. We have a collaboration with University Hospital Basel, where there's a long history of working with these drugs and a lot of sort of dose effect and comparative dose finding studies. We're fairly well informed about at least where we should be looking for the doses. I will say that the design of our phase 2 LSD study is very oriented around identifying the right dose to bring into phase 3. And there's some things to consider when you think about doses. One is, it can't be too complicated, right?
Yeah, true enough.
So weight-based dosing, while for some drugs it's really important, and of course there's some drugs you can only dose by checking level periodically,
right?
And you're actually in the right range. It sure doesn't seem like psychedelics are that kind of drug that on a population basis, you can probably get to a dose or a couple of doses that are right for the vast majority of people. And what we are doing in the phase 2 is a 5-arm study where we're looking at everything from a dose that we expect to be kind of at the perceptible threshold all the way up to 200 micrograms.
Oh, wow.
And yep, fairly decent dose of LSD.
That's wild.
And to not just look at the acute effects, though of course we will look at the acute effects, but to look at how those folks course goes over time, and to see if we have different rate of clinical improvement, different rates of remission. Also to look at what happens in the session to see if there's a dose that is effective, but either easier to manage in the session or causes less acute anxiety, this sort of stuff. So that is one of the things that I'm most proud of about the way we're doing this work, is that we're really trying to do good science along the way, and get to the right answers, so that when we prosecute a phase 3 program, we're doing it with as much information as we possibly can. And all of that adds up to the greatest likelihood of being able to get a drug to market.
Right. Fair enough. I love that. So I guess one of the other issues, and this is sort of like, it's a tough thing to quantify, is the state of the patient or whatever. And obviously that plays a role in how the drug's going to impact them and stuff like that. How rigorous is your kind of patient inclusion criteria for a study like that? Do you do a psychiatric evaluation? Is it just a kind of casual questionnaire, or what does it look like for an ideal patient to enter those studies?
Well, we do have to have some tightness around inclusion and exclusion criteria. You have to stick to what you wrote down, and the things you write down are the things that you kind of split the difference between the fidelity of the study. So how much the study has to do two things. It has to answer a question, and then as best you're able, you have to say, okay, this answer that we got from this study also applies to a wider population. So the more narrow your inclusion exclusion criteria are, maybe the higher fidelity the actual study is, but the less generalizable it is.
Right.
And so we're always looking
tricky.
at the right intersection of people who represent the real population as much as you're able, but also don't include confounders that might make the data more difficult to interpret. But so there's an element of psychiatric exam based on standardized. In clinical research, you try to do everything as standardized as possible. Working across 20 sites, you want to make sure that you're not getting variance between the sites on who they're getting in study where you're able. So standard questionnaires, standard interview with an investigator. Everyone's, there's blood draws and things like this to look at other biological things, and then people are followed at regular intervals with repeat instruments. So
fair enough.
The inclusion exclusion are on the clinicaltrials.gov site, which we have to post all that. And this is wherever it feels strange saying this because of all of the excitement about psychedelics that we feel and that everybody else feels. But at the same time, our orientation is to say it's a drug. Right. And our job is to prove that it's a drug, so that then it can be a drug in the real world. Right. And or possibly to discover it's not. In this case, that's in general psychiatric research. That's more of an issue because so many chemicals look like drugs and then aren't. The body of evidence that supports both the class and specifically LSD as a member of the class is strongly suggestive that we're sitting on something that ought to help people and ought to work. So then it's on us to do rigorous drug development techniques to robustly demonstrate that is
the variables. Awesome. So one of the interesting conundrums with this is you come as a patient with this issue, whether it is anxiety, and the I guess the irony here is that the drawback, the potential side effect, is falling into an anxiety attack when you're getting treated, right? I don't know how common that happens, but obviously that's how rigorous is that protocol where you're sort of like monitoring and minimizing the chance of kind of a downward spiral or back or bad trip, so to speak, happening through that process.
I don't want to minimize the experience of a bad trip for anybody, because for folks who've had them and described them, people have clearly had terrifying experiences and bad outcomes. Those were not in the clinical studies. It just wasn't. Really? The bad outcomes come from the anecdotes. They come from a lot of them. A lot of exaggeration of the risk that came from the political backlash in the 60s. So I always try to be clear that this is not the usual. It's not in any way the usual outcome for people. The usual outcome for people, even in relatively uncontrolled environments, is positive. That's why.
Does that come down to dose for the most part? Do you think there's like the bad trips have been kind of blown out of proportion, or a bit of both?
It's an intersection of environment, of internal state going into the experience, and of dose, of course. And when it comes to substances that are procured on the street, what was actually in the substance.
Yeah.
So what we've implemented is a protocol to keep folks safe and calm. And again, we'll see what we see, but we're not really expecting to see a whole lot of trouble. So what we have is two people in the room at all times with the patient, with the participant. And those folks are folks who have experience in, one of them is a licensed, provider in psychiatry. The other can be a little less credentialed, but still experienced, who have practiced and learned from folks who have a lot of experience conducting psychedelic psychotherapy, whether it's, in the States or particularly outside of the States, and have some really sort of well-vetted plans for helping folks remember what's happening if they can't. And what we start with for a lot of these folks who are going into the session monitoring and these trainings is, look, mostly what someone needs to be reminded is this ends. You can take a break, you can sit up, we can chat. Remember that you took drugs not that long ago, and this is just the drugs. Right? This is what we knew to expect. And when you're ready, why don't we go back in and keep doing what you were doing and see if you can't have the experience and lean into the experience. If
that's such a simple concept, but just tough to, like, you forget that you're still the same person and nothing else has changed. You just like took this chemical. Like, you feel like your whole walls can be caving down on a bad trip. It's wild.
Yeah. And to do these, the sites that we've chosen are sites that either have experience or seeking experience in the space, or really are interested in, really great psychiatric research sites that are oriented toward providing this type of care. They all have to have dedicated rooms for it. The rooms are not meant the rooms don't have to be standardized particularly, but they're not meant to feel like clinic rooms. They're meant to feel a little more comfortable and to make sure that folks have a comfortable place to be lying down, sit up if they need to. If they're ensuite bathrooms, so if someone needs to go to the bathroom, they don't have to go out and be in front of anybody else. So the entire experience is meant to provide that sort of, again, a psychotherapy concept that applies here. Like a holding environment where someone can feel comfortable letting themselves lean into the experience, whatever it feels like at the time, because they've been prepared, they've met these people, they've developed some trust in them, that because it's a professional clinical operation, we do strange things with clinical operation. We let people operate on us, So this is true. You might argue this is more invasive, but this is arguably, it's kind of down the middle for what clinics do. And so all of it oriented toward trying to ensure that folks' experience is what it should be, what it can be. It's not necessarily all positive, right? Did folks sometimes, when folks are having these sessions, memories can come up, or a new way of seeing old memories can come up, right? That can be not necessarily sort of positive in the moment, but that the person is able to move through.
Changes the way of thinking about it.
They can move through whatever, if there's some negative things that come up, that's okay, because they can move through them, and that's why they're there.
Yeah, absolutely. I love that. And sticking kind of with the concept of environment, I've read that music is used often. Is that like a universal thing? Do you guys use music in your clinical setting, or is that a little case by case? How do you decide on what's on the set list for that day?
A lot of people weighed in is how we did it. It was sort of a consensus process.
Okay, interesting.
People proposed components.
So just kind of relaxing vibes, almost like meditative sort of tunes.
It's not very lyrical, right? I mean, you want things that allow that sort of can occupy a bit of the brain while allowing the more thoughtful parts of the brain to go down and do whatever is going to happen in the experience. And nobody has to listen to music. Right? The music is available to folks who want it. I think people do tend to choose that for at least some of the experience, but for other folks that may be not what they're going for, and that's okay too. Right.
Love that. So we touched a little bit on neuroplasticity, and some of this is still unknown, but we know that obviously it's the neurotransmitters have a role as well. How much do we know about the role of dopamine, serotonin, and some of the other neurotransmitters in the process of getting this transformative effect from psychedelic treatment?
What I can say is that we know a fair bit about the acute effects. So we know that serotonin is implicated in the acute experiential effect of the trip. If you use that nomenclature again,
it's fair game for this chat, sir.
And we know that there's a deep relationship between dopamine and reward experience, right? Pleasure and reward. And these sorts of things have been demonstrated largely in animal models, right? And in animal models, you can do things that are meant to represent something a person might do, right? So if you give a rat a dopamine hit directly, or, you know, a dopamine releaser directly into the brain, you can get them to keep pressing a button instead of eating, essentially.
Sure.
How that, and you can then say, okay, well, that maps on to, say, addictive behavior. The harder thing for translation from animal models is these more human states, right? That depression, anxiety, these sorts of things.
Yeah, rat's not going to tell you a whole lot about how they're feeling. So
then you try to intuit it. And so for anxiety, you do things like put a rat on what's called an elevated plus maze, which has clear bottoms and opaque bottoms, and like measure how much time it's spending on the clear versus opaque. Less anxious rat goes onto the clear more. I mean, kind of, right? I guess. You know, for depression, it's still, we use something called the forced swim test, where you just sort of put the rat in a bucket and see how long until it gives up. A bucket with air in it. And I mean, right? If you squint, okay, I can see it's what we've got. But when it actually comes to the mechanisms of how we feel over time and how anxious we are over time and things like this, neuroplasticity comes up a lot, and because it's very sexy and appealing to think, oh, these drugs will just change my brain in a good way. It's important to remember when folks are talking about neuroplasticity that literally everything is neuroplasticity. Every single thing you do, everything you hear, everything you remember, every feeling you've ever had, all represent changes in your brain. Right. So psychotherapy generates neuroplasticity. Going to psychotherapy and having adversity is neuroplastic. Everything's neuroplastic. That's how our brain works. It fundamentally depends on structure.
Good night.
So lithium is neuroplastic. Lithium's incredibly neuroplastic, and it shows the same sort of dendritic growth that you might see from these things. So I love the idea, and I think it's really important. Sometimes people take me as sort of poo-pooing neuroscience. I'm not doing that. I think it's really important we keep trying. It's just also really important we don't overstate what we know from neuroscience that's applicable to a particularly chronic human experience. And so that gap is quite wide still. Right. If in fact these drugs induce a period of neuroplasticity, we may discover that there are things that folks should be doing during that period of neuroplasticity to maximize the benefit of it. Right. But hard to really conclusively say much more than that about people.
Yeah. Actually, I wanted to ask you about that as well. So I assume kind of more traditional treatments for these people are going to help, and there's somewhat of a synergistic effect. Have those been studied kind of in concert with psychedelics, stuff like psychotherapy, exercise, nutrition, sleep therapy, supplementation? Is there one specific type that tends to lend well with drugs, or are we just kind of still figuring that stuff out?
So we know that psychotherapy, good psychotherapy, and it's hard. This gets a little circular because what is good psychotherapy? What is psychotherapy? It helps you. But to me, good psychotherapy is depth psychotherapy that works on underlying characterological defenses. Right. I mean, that's really what psychotherapy's job is.
Getting to the root issue, in other words.
Try to get at, well, all of the theorists agree on some things, and one of them is that as a developing child and then adolescent and then even through adulthood, the mechanisms we use to protect ourselves at one stage or from one perceived threat can stick around and be reapplied in places where they shouldn't be. Right. And that's fundamentally that's what you're working on when you do depth psychotherapy, is how do we make sure that defenses that were either adaptive or maladaptive at the time they were adopted don't carry through and do maladaptive stuff in the person's life. Right. So good psychotherapy helps people. There are a number of drugs that help people, though, which people, how and how much is still up for debate. And so that every time they're looked at together, we discover that these things work together, right? That if you do both, you get better results than doing one or the other. I think that the particular, particularly if the experience matters, but the sort of the nature of the psychedelic, experience, possibly mechanism, lends itself particularly well to psychotherapy. And then everything else, that you listed, yes, like people should be engaging in behaviors that that both acutely make, so and psychotherapy is a little bit of a contradiction, because if you walk out of psychotherapy feeling better, you might not be doing hard enough work, but over time it should make you feel and be better.
Right.
But taking care of oneself does not necessarily mean only doing things that make you feel good, right? It means doing things that have
challenge yourself,
maybe have longer term objectives as well. And some combination of the two that works for the individual is probably where the money's at there.
Yeah. Do you have I don't want to build this to death, but if you had to choose, I guess, between, say a person is open to psychotherapy, they're open to exercise, nutrition, sleep, supplementation, do you have a sense of which direction you would kind of guide them in if they had to choose one of them?
So, I mean, if someone hasn't done a good course of psychotherapy, or they have and they're not feeling psychiatrically healthy, then I think psychotherapy. I think if you can get good psychotherapy, absolutely get good psychotherapy.
Right.
Very little I'm aware of is much good for people. Sleep is clearly incredibly important.
Right.
I don't know what sleep does either, by the way, or why we have to sleep. So, there are theories about that. But but despite us not fully understanding sleep, it's it's important. You got to have all these things figured out about sleep hygiene and things like that. So very much support that. Exercise, and for me, I don't set aside time to exercise, but I always try to walk places when I'm trying to get to places. So I do a lot of walking, and I play some games, that involve running around. Sure. But just, being active better than not being active. And then diet, when it comes to diet advice, you say you're liable to sound silly tomorrow if you say something too specific today. But in general, don't eat too much too often is probably pretty good advice.
A little caloric restriction.
Probably not like a ton of calories from processed sugars, but also some are okay. It's all things in moderation, including moderation.
Fair enough. I love that. So you've been working mostly with LSD, and it's almost like these psychedelics are getting lumped together with psilocybin and MDMA and a few of the others. Do you have a sense, or do we know really? Is there a drug preference? Is that kind of dependent somewhat on the variables around the patient specifically? Are they all still kind of are we all at the same place in that research, or how much do we know about the differences in different kind of psychedelic agents?
Also, really good question, and something that we often find ourselves kind of clarifying when we start talking about classes and drugs is that the excitement about psychedelics, and specifically the word psychedelic, has caused a bunch of things to be lumped under a tent where they maybe don't belong. Right. So ketamine, for example, and S-ketamine, which is the Janssen product, Spravato, those aren't psychedelic, right? And when used carefully in a proper dosage, sometimes people don't feel an acute effect at all, but they seem to pretty reliably cause rapid reduction in severe depression and reduction in suicidal ideation. That's awesome. Not psychedelics. Right. MDMA, which MAPS is advancing in the treatment of PTSD. By the way, the MAPS program is different because theirs is really about combining drug plus psychotherapy. So the evidence does not suggest that MDMA in isolation is helpful for PTSD. So they're doing psychotherapy plus MDMA. And the point there is that the psychotherapy is able to accelerate and get more depth to it quicker, because the MDMA builds a sense of trust between the provider and the patient, and empathy and all the things that are kind of necessary for psychotherapies to work. In the middle there are the sort of core psychedelic medicines, which, they're psychedelic drugs, which, psilocybin, mescaline, LSD, DMT, 5-MeO DMT, a couple of, there's some others that are slightly different, like ibogaine. And so how will we know who should get which? And you asked about dose before, at which dose, when, with what sort of preparation, what sort of follow-up? Those are the questions that we got to answer. Yeah. But again, and I always fall back on SRIs as the example. We still don't really know which SRI we should start on. So I hope that as thoughtful folks trying to help people, that different companies which have different assets, different drugs, there are ways that we can try to work together to develop the body of evidence as to who should be getting what at what dose and when, and these sorts of things. And that's partly what we're doing with our digital medicine effort. at MindMed is looking at ways of measuring people in a more fine-grained way so that we can start to understand maybe these diseases in a more fine-grained way and individuals in a more fine-grained way, and really start to try to be able to create some decision support for clinicians around how to make these choices with the best evidence they can.
Yeah, fair enough. So, and kind of to your point, we're still in an early phase here, and I guess depending where you are in the world, logistically, legally, we're kind of limited. What are the current options for people who are interested in medicinal therapy? I guess throughout, is it where are we at kind of with logistics legally?
So there are studies is one way to access a study drug. Now you may get study drug, you may get placebo in some cases. In other cases, you may be in an open label study and know you're going to get the drug. So that's certainly one way to do it. But there's not. If studies were enough to treat everybody, then we'd never have to stop doing studies. We just but there are not really outside of studies, really many legal avenues to acquire these drugs. Most of certainly from a federal perspective, these drugs are Schedule 1 and are federally not legal. And in order to do research with them, we need special permission from the government to be able to do that. So it's a hard thing to say, but for folks who are suffering and think that this will be helpful, get help in the meantime. There are options while these are on the way. And even if you think you've tried everything, find someone who's good at psychotherapy, find someone who's good at psychiatry, if you're at all able, because these aren't magic. I hope, because if they're magic, all bets are off on science. And while we're extraordinarily hopeful that they will help a lot of folks, no one should be waiting. Right. Everyone should be trying to, don't wait for me to finish my job to try to feel better. There are options in the meantime to feel better. Yeah. And just because it feels like you've tried, the number of patients I've seen who say I've tried everything is high. And guess what? They haven't tried.
Yeah. Sure enough. Right?
Everything's a very, very big box.
Yeah.
So there's probably something out there, and probably many things out there that you haven't tried. And so that's my, waiting to get, the time spent waiting to get better is time spent not better.
True. Yeah, you're right. This is kind of a loaded question, but do you have a sense of if and when we might see a change, or what are the current barriers, kind of like the red tape sitting around getting this opened? Is it just more like, do we need like 10 more years of research? Do you have a sense of what that'll look like?
We're on the 4 or 5 years of research. In evaluation, that's the timeline, I think, realistically. But for true psychedelics, MAPS and MDMA maybe in front. Compass is developing psilocybin and doing what they can to do that as expeditiously as possible. But I think no matter how much we want these to work, no matter how much everybody wants them to work, no matter how much the regulators want them, regulators have the same goal we do, which is to be demonstrated to that these drugs are safe and effective and need to go to market. So the reality of these processes are they have a pace, and you can pull levers to accelerate them, but only so much. Yeah,
fair enough. And so where does that leave MindMed? What can we expect from MindMed over the next 4 or 5 years in the meantime? Is it you're just kind of looking for funding, adding some more studies to the ducket?
I think the macroeconomic environment for biotech is what it is right this minute. That is not going to stay that way. We obviously will need more money over time to bring these drugs, more than just LSD. We have our MDMA program for autism, which is an entirely different way of thinking about MDMA than the way that MAPS has been thinking about MDMA.
Interesting.
So it just, we're thinking of a daily dosed drug that helps folks with autism with social expression and social communication, which a really exciting concept. And then as finance situations change and the environment changes, our goal is to build a brain health focused pharma company. And there are a few examples of folks who've done that in the past. We're starting with a a molecule that captures some attention for sure, for obvious reasons. And that's a good thing. But that's not the end of the MindMed story. The MindMed story is a longer and I hope even more influential tale in its ability to inform what I think of as the next stage of psychiatry and psychotherapy.
Awesome. Well, it sounds like you guys are doing pretty amazing work. Dan, I want to expand this a little bit to your kind of personal. We talked briefly about your protocol with exercise, and it's easy to kind of get lost with what your own priorities are around your health, especially when you got a busy work schedule. What's at the top of your list in terms of your health and wellness, in terms of priorities, and what your habits look like around that?
Yeah, and I always am a little cautious talking about too much about my own stuff, because it's another tendency in this world to very much focus on, well, if you had the experience. And in medicine in general and in psychiatry specifically, there's an appeal to that, right? To appeal to my experience as being informative. And so when I treat patients, it's more important to remember that they are not me. Than to try to identify with how they are me.
Yeah,
right? What works for one person.
It's the same thing as a coach. Like, your first thought is, this works so well for me, this must work for the whole world. And you kind of have to keep those two as separate things. It's worked in this one case, and I am patient one. Client one.
And I have way more access to I may or may not have way more access to my internal state than I do to somebody else's internal state.
Yeah, for sure.
A lot of things.
Yeah.
So, but I think what I said before covers it pretty well. And particularly when busy, when sleep. I flew in on a red eye last night, and I'm feeling pretty good. But the thing I learned in residency is, if I'm going to not get a good night's sleep, I probably shouldn't eat a whole lot that day, or particularly that evening before not sleeping, because I feel really happy the next day if I got that all. So a lot of the things that I think, the way I experience my day to day is the things I can control are not my schedule. Right. So things that take up time, that are adding time to my calendar, might be more stress inducing. So a lot of what I do is, can I walk to the office from home in the morning, even if that means taking my first call while I'm still walking, right? Yeah. I try to be pretty cognizant of what I eat and when I eat. But again, I don't have super specific dietary advice for anybody. I just sort of know what makes me feel good and what kind of keeps me at a weight that I'm comfortable with the amount of exercise I actually have time to do. Yeah. And then some of the best advice, I think, particularly are like, what do we call this? The post-COVID world? I don't know. I still hear a lot about COVID. So it depends on your perspective, I guess. But in a world that's been so affected, and with a population of people who've been so affected by COVID, is that we are social animals, even if it's easy to forget that, because it's not to be social, and sometimes being social is hard, and for some people it's hard. It's being social is stressful, but to find opportunities to connect with people. I think connection is an antidote to an awful lot of kinds of distress, for sure. And maybe the best advice for that is, if you're struggling to feel connected or to find connection, got to find plans. The way to make friends is to make plans. And so whether that's one-on-one plans, or plans to go join a group of people who are interested in something you're interested in, the way to make friends is to make plans. Yeah.
Well said. I absolutely agree. Well, Dr. Karlin, it's been an unbelievable chat. We appreciate the time. What's the best means for people to learn more about you and what MindMed's up to these days?
Certainly the MindMed website, mindmed.co, is the source of all our official information. We get covered periodically in the news and by analysts and stuff like that. So when there's something out there, it's probably something we said or did. So feel free to check that out. And if folks, there are ways to get in touch with us on the website if folks have specific comments or thoughts, or we read our mail. So if you've got thoughts from us, do feel free to let us know.
Awesome. Yeah, we'll link to that in the show notes. Well, again, appreciate the time. It's been a great chat, and wishing you all the best.
Yeah, total pleasure. Thanks for having me.
Pleasure. Thanks for doing this episode of Healthspan Academy, guys. We'll see you next time. Hey, what's up, guys? Thanks for tuning in today. Hope you enjoyed the episode. Thank you so much for supporting this channel. This has been a fun project. We're growing in viewership every single week, and we obviously couldn't do that without you. So thank you for continuing to tune in. I really hope you're getting value out of the programming and the content. Just wanted to give you a heads up. I've been working on a book on health and longevity the last couple of years, been collaborating with my colleague, Dr. Dan Vitale, who's an expert in the field as well. And we've basically just kind of summarized the literature, some of the techniques that we found really useful in the world of biohacking, what our exercise regimen looks like, what's, cardio type stuff is going to help us live longer and healthier, mobility work, nutrition. We've covered the whole spectrum, everything that you can basically be in control of in your health and fitness kind of moving forward to help you live as healthily as possible for as long as possible. And it's available free for download. So if you click on the YouTube banner, you'll see a link to download the blueprint. It's also on our Instagram profile or on the website. You can click on 5pillarmethod.com/optimize to get your free copy of the book. And I hope you enjoy it. Hope you're keeping well. Thanks again for tuning in, and we'll see you next time.